Okay, so in this episode, we'll be talking about narrow-complex tachycardia arrest, usually less than 120 millisecond. We're going to start with the diagnostic approach. Always determine the QRS width and assess the rhythm, whether it's regular or irregular, and we're going to look for P waves to do that, location axis morphology, and always compare to baseline ECG. So the treatment, if it's unstable, we're going to start with synchronized cardioversion, so that's unstable hemodynamics. If it's stable, we can try vagal maneuvers as well, Valsalva, ice water, and also adenosine for AVNRT or AVRT. And that can be diagnostic or therapeutic in those cases. For the other ones, beta blockers, calcium channel blockers, and amiodarone. If we were to cardiovert, and if it was a stable patient, always rule out the intra-atrial clot if it's atrial fibrillation or atrial flutter, if the patient hasn't been anticoagulated in the past 3 weeks. Regular narrow complex tachycardia, sinus tachycardia. This is usually max heart rate 220 minus the age. Sinus tachycardia doesn't go above that general rule. So always have to find the underlying cause. This can be very common, especially in the hospital setting: substance withdrawal, alcohol, benzos, opioids, even beta blockers, fever, infection, of course, hypoxemia, PE, anemia, hypovolemia. Next up, ectopic atrial tachycardia rate 100 to 200. We have automaticity from a single atrial focus or intra-atrial re-entry. And P waves can sometimes be present but abnormal in morphology. Next up, junctional tachycardia, such as AVNRT, atrioventricular node re-entry tachycardia rate can be up to 250, 100 to 250 beats per minute. This is a re-entry within the AV node. We can sometimes see retrograde P waves when the vector is firing away from the leads. And these are usually seen in young adults, female greater than male prevalence. Next up, AVRT, orthodromic atrioventricular re-entry tachycardia, rate 140 to 250, and we can see accessory pathway, AV node ventricle accessory pathway, and up to the atria again. Next up, irregular narrow complex tachycardias. We start with MAT, rate 100 to 150. This is multifocal atrial tachycardia. We can see P waves, but they're usually different in morphologies. Next up, atrial fibrillation. The most common P waves are absent here. There's chaotic atrial electrical activity originating from the pulmonary veins. Next up, atrial flutter. We have that classic sawtooth appearance. Atrial rate is the highest here, 250 to 300. You can see the flutter waves, and sometimes we can see patterns 2 to 1 or 3 to 1 conduction with variable AV block as well.